So I'm Dr. Elena Rios, and we're here with our number 4 virtual briefing on COVID-19. And every month since May, we have had a discussion with experts on different topics. And tonight we're very happy to have a sponsor, AARP, and to have with us Yvette Pena, Vice President of AARP. And Yvette, I have to tell you, my father went to the high school that had the teacher who started AARP.
Wow, what an honor.
Lincoln High School in Lincoln Heights, northeast of downtown Los Angeles. And so it's always been a story in our family about the importance of AARP taking care of our seniors. Even though when I got my card when I turned 50, I didn't think I was a senior. But anyway, Yvette, why don't you take it away for a few minutes?
Sure, thank you, Dr. Rios. What a wonderful story and what an honor to be connected to our founder, Ethel Percy Andrews. Hello, everyone. I'm Yvette Pena, Vice President of Multicultural Leadership at AARP. Thank you so much for joining us for this important discussion, our new normal during coronavirus. AARP is so proud to sponsor this session, and we want to thank Dr. Rios for her leadership, as well as her hardworking team. And of course, thank you so much to our expert speakers. Just a few months ago, our daily routines were completely upended, steadily transforming to this lifestyle that we now call our new normal. While we might be getting used to it, this new normal is far from easy. We may be more confined to our homes, not being able to see our kids as often as we'd like, our grandkids, and engage in social events, or we may be dealing with the situation of loved ones in a nursing home with restricted visitation. As masks are becoming a part of our everyday lives, and we're mastering the art of social distancing, this takes an emotional toll on us and our families. So we can't forget to take care of ourselves. It's okay to take a breather. Take a breath in. You are the center of your family's universe, and being here today is an excellent way to invest in your mental health and your physical health. In just a few moments, that is just what we're going to discuss with our experts. How you can stay healthy, connected, and build resilience by being informed. Frequent updates of the utmost importance right now and new information and medical developments happening are things that we must keep top of mind. We all need to stay as informed as possible, from everything to the most effective masks, to social distancing, to what kind of hand sanitizer we buy. Such things have become an essential part to our daily routine and may remain so for quite some time. So make sure to educate yourself and your loved ones by keeping up with the latest data. And now I'd like to tell you the many ways that AARP is helping our older adults stay informed during these times. We want you to know that you can rely on AARP to provide you with trusted information, especially during this pandemic. We have updates on aarp.org/coronavirus and in Spanish at aarp.org el coronavirus. It's real-time information for you and your family. We also have a platform that brings people together virtually to address social isolation and other challenges. We call it AARP Community Connections, and in Spanish, Mi Comunidad con AARP. And you can reach them by aarpcommunityconnections.org or logging into aarp.org Mi Comunidad. And we also continue fighting for the 50+ population, not only in Washington, but around the nation. We work hard to continue allocating sufficient resources to address the outbreak. We help secure funding for the vaccine research, funding for doctors and healthcare providers, and expanded unemployment insurance benefits for those who are out of work due to COVID-19. But there is so much to be done today. For this reason, I want to thank all of you for your willingness to learn with us today, and thank the National Hispanic Medical Association for putting together this wonderful series, because now more than ever, it's important for us to be there for one another. And here at AARP, we support you by providing the most trustworthy resources, because we know that juntos es posible. Muchas gracias, and enjoy the briefing session.
Thank you, Yvette Pena from AARP, and again, thank you for your support. I have a few slides, and I just want to make sure everybody knows our housekeeping rules. We have brief presentations. We will hold questions after the presentations. You can put your questions in the chat box, which is at the bottom of in the middle of the bottom of the Zoom display. Please mute all your microphones, and a recording will be available next week at our website, National Hispanic Medical Association, which is www.nhmamd.org. Ben, next slide. And just to kick it off and to give you the context here, we do have some statistics. The total cases of COVID in the United States at this point are over 5 million, and the total deaths are 177,000. And I have to say that Latinos and African Americans are known to be many more than the white counterparts in our country. And just by looking at some of the states where we have the most Latino populations, you can see how huge the number of cases are and the percent of Hispanic and Latino cases and deaths by state. I'm not going to read all these numbers, but just know that we know, because of the historical social determinants of health, our communities tend to be more poor, with less safe walking areas and more crime. We live in toxic stress, which means we end up having diabetes and obesity earlier in life, and hypertension. And of course, with all the environmental changes that have happened in our communities, air pollution, water pollution, we see a lot more asthma and other chronic diseases. And that's part of the reason why we do have a bigger impact from this COVID-19 disease on our communities. Ben, next slide. So the mission of NHMA has been to improve the health of Hispanics and other underserved. Now that we are going to talk about what is the new normal, I would just want to tell you that we have a very important message, and that is that we encourage you to enroll and to inform others about enrolling in clinical trials for the COVID-19 vaccine. I don't know if you know this, but when polio had a vaccine, it took 5 years for the disease to really be gone. When smallpox was eradicated with the vaccine, it took 3 years. And we're hoping with technology and the speed of science that it won't take us that long, if we can get a vaccine, to have back to what we call a new normal. And right now, minorities have never been part of research, less than 10%. And I just have to tell you that what you need to do is have a couple of injections and 4 follow-up visits. The goal is to have 30,000 people, and I just heard from the Department of Health and Human Services that the Moderna vaccine there has 10,000 people already enrolled. So it's moving along. And I just want to make sure that you see these 2 websites. The coronaviruspreventionnetwork.org it tells you all the over 100 locations across the country to sign up. And then the other website is for the Pfizer vaccine clinical trial, and that's covidvaccinestudy1.com. And of course, NHMA also has information in English and Spanish on our portal for COVID, and that's called hispanichealth.info. So let's get started. Our first speaker is Dr. David Grube, National Medical Director of Compassion and Choices, and he will tell us about some wonderful toolkits that he and his team have been developing. Dr. Grube.
Thank you very much, Dr. Rios. I'm so glad to be with you here this evening and afternoon. I'm in Oregon, so it's still fairly early in the day, but it's my pleasure to join you. Before we begin, I would like to take a moment to think about those who are suffering from this illness, and to think about those of you who are caring for them, and to thank you for that. This is a terrible time in the world. Dr. Rios was mentioning smallpox. I happen to have been in the middle of a smallpox epidemic in Yugoslavia in 1972. I never thought that I would be in two such epidemics, but I just wanted to take a moment to thank you and to think about those who are suffering from this terrible disease. Next slide, please. Compassion and Choices is the nation's oldest and largest nonprofit organization that speaks to empowering individuals to have improved end-of-life care and to be able to have options for that care. What I've been asked to speak about tonight is planning for the end-of-life issues. And of course, with the COVID-19 event, things are all different now. So I was asked to present the information that we have on our website, which is compassionandchoices.org, about particularly in regard to advanced care planning or advanced directives, and especially in relationship to the new normal of COVID-19. So this is just a picture of the website. It's a very easy website to access and to read, as are most advanced care planning documents. It's in not only English, but also in Spanish, which I'll show in a minute. Next slide, please. So as you see from the, if you roll down on our website, the next thing that you would come to is this thing, which talks about end-of-life decisions, guides, and toolkits, finishing strong and taking control of your care, empowering an individual to do that. And then also we offer a doc-to-doc line. This is a line that, or phone line that any physician can call to receive counsel regarding end-of-life choices, options, and considerations. There's no charge for that. It's staffed by licensed physicians in various states. I actually staff that from time to time. But I want to focus on the bottom part of the screen, which is the COVID-19 toolkit. And next slide, please. This toolkit has, as you can see, 7 or 8 websites that discuss COVID as a disease in language that's understandable, and then the considerations that an individual might have, and then how to complete an addendum to your advanced care plan or advanced directive in time of the pandemic. I'd like to briefly go through the various parts of the toolkit, not at length, but just so that you can understand what's available. I think it's a very helpful toolkit. Next slide, please. So the first area in the toolkit is understanding options. Who's most affected? What are the symptoms? This is updated all the time, so it's currently up to date. I just looked at it yesterday. What do I need to think about if I become seriously ill? And what are my different treatment options? And these are all outlined and explained to an individual so that an individual can consider these things when they're filling out their advanced healthcare plan, and talk about these things with their family, of course, which is so important. Next slide, please. It explains information regarding telehealth. I know that you have had previous sessions on telehealth. Telehealth is new to us as healthcare providers, although it's turned out to be something that's probably going to remain present after the pandemic. But also, general questions regarding telehealth are available and explained. Next slide, please. Advanced care planning. There's never been a more important time for us to get our advanced directives completed, updated, and changed if and then amended. And we have an amendment I'll show you in just a minute. I've been working with patients since, gosh, I think 1980 to get people to do their advanced healthcare plan. And I honestly believe that it's more important than ever. Next slide, please. So this is, oops, there we go. This is the addendum for the to advanced directive in the pandemic. There are I think there's 9 questions that are asked, and then you complete on this. I don't want to go through them all, it would take too long. But there are questions such as the first one, if your oxygen levels are dropping, do you want to go to the hospital, or would you prefer to get non-invasive respiratory therapy at home? And you understand why we have these kinds of questions, but they're so important to get answered. The value of them, not only in completing this advanced directive, is to think about the answers, but to talk about it with your loved ones, with your family, with your healthcare representative. So this is all available there on the website, and I won't go through each step. Next slide, please. And then the last part, the last section, second to last section is if you want to avoid the hospital, what can be done? Saying goodbye, which is a very difficult section to read, but it's very important for us to talk about these things, particularly if we're in high-risk areas. And then memorializing loved ones when we can't be present at a funeral, etc. Next slide, please. The impact on underserved communities, as Dr. Rios so eloquently explained, so much higher in the communities of African Americans and Hispanic and Latinos. I put this one slide up there to show that these statistics are now a month or so old, but a much greater share of the confirmed cases compared with other cohorts in states such as Wisconsin, Delaware, Arkansas, Iowa, etc. So there's a section in this, next slide, please, on the toolkit. This slide is too small to read, but it just confirms what Dr. Rios was saying, that communities in the Latino, Hispanic areas need to be more concerned, unfortunately, because of the social determinants that she described. Next slide, please. So, as I mentioned, this is all in Spanish. I apologize. I took 2 years of Spanish in high school, but that was right after the turn of the century, the last turn of the century, so I don't remember my Spanish very well. But all of these are available in Spanish. Next slide, please. So I'll close with this quote from Dr. Pasteur, who says that we don't ask one who suffers, what is your country? What is your religion? What is your cultural background? We say, you suffer, this is enough for me, and you belong to me, and I will help you. So I want to close thanking you for the help that you are providing those individuals who are suffering at this time, and for your courage and your strength and your talent. Thank you very much.
Thank you, Dr. Grubin. And again, thank you for your support for this series from Compassion Choices. Next, we have Winifred Quinn, who's going to talk from AARP's Center for Champion Nursing in America. And Winnie, I have to tell you, my mother was a nurse. So, you know, I come from a nursing family. What can I say? Anyway, she's going to talk to us about people, nurses, and telehealth.
Yes. Thank you so much, Dr. Rios. It's so nice to see you again. And thank you and to Yvette for inviting me and inviting the Center to Champion Nursing in America to join me this evening for this very important conversation. So the Center to Champion Nursing in America is 13 years old, and At the time of its inception, it is a joint initiative of AARP Foundation, AARP, and the Robert Wood Johnson Foundation. And at our inception, there was a pretty severe nursing workforce shortage, and so that's why the original intent behind it was to address that. And we did, and while we were underway with that, we also got involved because of state offices asking us for help, AARP state offices. We got involved in APRN scope of practice policy issues and access to care. And then the Robert Wood Johnson Foundation partnered with what was the Institute of Medicine and what is now the National Academy of Medicine to generate a report on what would nursing and nurses need to do to become a truly effective 21st century workforce. And I do want to preface a bit of my credentials were removed from the front slide. So I'm not a nurse. I am a family caregiver who works on healthcare issues as they intersect with what people need and what nurses can do primarily. And I also work on analyzing telehealth policy. That FAAMP, there should be an honorary sign after it. I'm an honorary fellow of the American Academy of Nurse Practitioners. I'm honored for that. So if you could, there we go. So the IOM produced a report called The Future of Nursing, Leading Change, Advancing Health in 2010. And the AARP submitted an application to the Robert Wood Johnson Foundation to run a campaign that would initiate, organize, and implement the findings and the recommendations from the Institute of Medicine. And so we focused our efforts. We've been running a national campaign for just under 10 years. These are the 6 pillars, so to speak. And diversity in nursing, diversity and inclusion in nursing is one of them. And so I get to be lucky enough to be the coordinator of that work. Next slide, please. So as Dr. Rios had mentioned in her welcoming remarks, most of what underscores health and well-being of people in this country are the social determinants of health. And unfortunately, most underprivileged, if not all underprivileged people, historically marginalized people such as Hispanic communities, African American, Indigenous, Native American, National Alaskan people don't have equal access to these determinants of health. They often lack access to safe and affordable housing. They lack access to transportation. They lack access to high quality education. And I, in my most recent paper that I'm writing on telehealth, I'm also making a point at the end that I think that connectivity is also going to be a new social determinant of health. Next slide, please. So these are factors that add up to people's health outcomes. I'm not going to spend time on this because I want to get to the new normal. So if you could advance the slide, please, Ben. So we know that by diversifying the nursing workforce, people will obtain more culturally appropriate care. So when nurses are either from or familiar with the communities that are being served, they are more likely to understand the social determinants that are affecting the communities and how those social determinants are affecting the people's health. And so rather than making assumptions, erroneous assumptions about what is occurring in a person's life, they can understand how to incorporate and how to address the social determinants that are affecting that person's health. And so we focus on diversifying the nursing workforce to help reduce and eliminate healthcare disparities and to achieve health equity. And I want to point out that most of the photographs like this of these 2 fabulous nurses, when COVID hit and we all went into remote and virtual setting, I emailed one of the distribution lists of the nurses that we work with, of about 200 nurses that we work with, and I asked for photographs of people live and in action. And so most of the photographs you're going to see on the slide deck are actually from nurses who sent us those photographs in April and May. And they gave us permission to share their images. Next slide, please. So to help ensure that we are doing the right thing when it comes to diversity and equity and inclusion in nursing, we created in 2012 what was the Diversity Steering Committee and is now the Equity, Diversity, and Inclusion Steering Committee. And it includes the presidents of all of the organizations that are part of NCMNA, which is the National Coalition for Ethnic and Racial Minority Nursing Associations, as well as the American Association of Men in Nursing. And so here's a great photograph of the last time we were able to meet in person, which was last October, with our funder, Sue Hassmiller from the Robert Wood Johnson Foundation. She's second to right with the yellow sweater in the back, and our diversity consultants. Most of our diversity consultants are also here. I also want to point out, first of all, I want to thank every single clinician that helps people in this country and people around the world who obviously take care of patients and family caregivers, but especially now in the middle of this pandemic, when it is healthcare providers, it was clinicians like yourself, physicians, nurses, respiratory therapists, others who also are becoming ill just by giving care. And the president of the Philippine Nurses Association of America actually had COVID, and as did some of her family members. And so this is striking home. This really strikes home for our EDISC and for the people we work with and the people who all of you serve. So again, thank you from the bottom of my heart on behalf of AARP's 38 million members. Next slide, please. So I wanted to brag a little. I think that the work that the Campaign for Action has done has helped. We are one of the factors, one of the many factors and many organizations that have really organized over the last 10 years or so in helping to create a more diverse nursing workforce. As you see here, the diversity has grown in terms of race and ethnicity, slightly also in terms of gender. That's not on here. But in 2008, when we started this work, men in nursing comprised about 9% of nurses, and now they are about 12%. If you go to the next slide, please. The pie charts are to tell a good story in terms of race and ethnicity. And you'll see that in 2008, 83% of the nursing workforce were comprised of people of color, even though at that time, so that would have made 17% comprised of nurses of color, not white nurses. I think I misstated that before. But almost a third, if not a third, of the nation's population 12 years ago was comprised of people of color. So we have a long way to do. Our goal, our dashboard measure, is that the nation's nursing workforce center and each state's nursing workforce would reflect the makeup of the nation and the makeup of each state. So we are getting there. If you could go to the next slide, please. The prior slide showed that the Hispanic nurses in 2008, 12 years ago, comprised 3.4% of the nursing workforce. It has grown almost 3 times the amount since then. So it's now 10.2%, or as of 2018, when the National Nursing Sample Survey from HRSA, the data was collected. The data were collected then, and the report was sent in January of this year. So next slide, please. So how do we do this? So we have the Equity, Diversity, Inclusion Steering Committee helping us provide guidance in our work, and we have organized action coalitions in every state over the last 10 years, and there are still 43 active action coalitions out of the 51 that were created. And any of the action coalitions that received RWJF funding, which was 43, they each had to create a diversity action plan. And at that time, when we first started, there was most of the nurses that we were working with were white women, tending to be in their 40s, 50s, and older. And so we provided many good challenges to the nurses that we did and are working with, and one of them was pay attention to diversity, and they really rose to the occasion. And so the action coalitions created diversity action plans, and many went above and beyond. They obviously included more diverse nurses and others on their decision-making bodies so that they could focus sort of along the lines of what we did in terms of creating an equity, diversity, and inclusion steering committee. They also brought in diverse voices and people into their decision-making bodies. Some have created a toolkit for ethnic minority recruitment of faculty and students, and several are testing a toolkit that we just generated, we just put out earlier this year. It's a health equity toolkit. And another action that the action coalitions are taking is we, in the last several years, have put a lot of our resources into mentoring. And so many of the minority serving institutions, which we started with HBCUs, historically Black colleges and universities, they already had mentoring programs. Some did not, but most did. And some were very active and some were dormant. So we wanted to support their work on mentoring because we know that mentoring is a very effective model in terms of retaining students of color and helping them pass their NCLEX. And what had been occurring was over the last several years, there was a really nice influx of Hispanic and African American students from those populations into nursing schools. They didn't have as much of a success rate as their white counterparts in staying in school and passing their licensing exam. And we know that we witnessed that mentoring was a very effective model at helping schools do that, retain their students of color and graduate them and help them pass their NCLEX. So we created this mentoring support program. Next slide, please. And so the action coalitions, anytime we convene the HBCUs, and now we do so virtually, we invite the action coalitions where from the states that the HBCUs are associated with. And so this was a photograph taken at last year's White House Initiative of HBCU's annual conference. They invited us to host a 2-day session with them at the convention, and we did. And so why do we do that? Again, for retention and graduation rates, also for supporting each other in our virtual environment now, and we would be doing this virtually anyway with the HBCUs. The faculty and the deans and the other administrators are really sharing a lot of information and finding resources that we could share with the HBCUs and other schools of nursing, creating a culture of cooperation, and hoping to also foster, if it's not already there, this lifelong support for mentoring. So a progressive culture of mentorship. Next slide, please. And so this was another picture of us at the reception that we hosted with the presidents and provosts the night before our 2-day program. Next slide, please. And so our ongoing work. So again, we are convening the HBCUs virtually once a month. We have webinars and sometimes just teleconferences. We ask what it is that they would like to focus on. We just had our most recent webinar was 2 weeks ago, and it focused on resources available from NLN and others, the National League for Nursing, and other organizations for simulation, how simulation is used successfully for clinical training. So, so we have the Learning Collaborative, and we are also now in our planning stages for convening Hispanic serving schools of nursing and Native American serving schools of nursing. And we are working with the National Association of Hispanic Nurses with the Hispanic serving schools. They are co-sponsoring the event. We also, with all three sectors here that you see, we work on the planning committee, also includes representatives from the U.S. Department of Health and Human Services Office of Minority Health, also representatives from HRSA, and with the Native American nursing group that we're working with. Our work group is also has representatives from Indian Health Services. So we're working very collaboratively with the schools of nursing themselves, with the national organizations that represent the nurses, and as well as the federal government. Next slide, please. So some short-term successes. The Maryland HBCUs organized themselves and just got a very good grant from the federal government where they have they're convening all of the HBCUs in the state of Maryland and the University of Maryland for a statewide mentoring program. And then at Cone Health in North Carolina, the dean there is, the dean from North Carolina A&T is on the board of Cone Health, and we have created with our Health Equity Toolkit, she is working with the Director of Nursing for the staff nurses to use the Health Equity Toolkit, so incorporating social determinants of health in the locus of care. Next slide, please. So the new normal that we're learning is simulation. There is a lot of simulation occurring now for the clinical work. We know that many healthcare locations, especially nursing homes, have had to and continue to not accept nursing students for their training, for their clinical training. And so so there's more simulation. And we're also hearing that, especially from the HBCUs, that the students are really struggling. For those students that do get to go into on-site clinical placements, they are really struggling to find PPE and or to afford the PPE. So the shortage of PPE is really affecting the students of color. And then, of course, in the middle of all of this is the racial and social injustice movement. And you know what? We are pretty much poised. We are here with the right resources at the right time. Many of the white faculty from especially the Hispanic serving schools and the Native American serving schools, where the faculty is predominantly white, they are asking for resources to help support their historically marginalized students that they are serving. And so we are creating curriculum for our convenings with them that will help answer their requests. And then next slide, please. So telehealth, Dr. Green covered a good part of this, and I know that NHMA has had an entire webinar on it, so I don't have to be too repetitive, but I will share with you that in June, our teammates in AARP Research, they did a study and found that, of course, over the prior 2 months, there was a significant jump in the number of people who not only were now using telehealth, meaning patients were using telehealth, but they were starting to feel comfortable in it. Interestingly, for this population, something that this audience should know is that the Hispanic respondents significantly reported barriers whereas about 20% of white people and 25% of Black African American people noted that they had barriers in terms of not having the computers or not having internet. 42% of Hispanic people reported that. So double or near double in relation to their white and African American counterparts. And telehealth policies and the changes that have occurred over the last several months are those policies that we continue to track. And the next slide, please. So that's us in a nutshell. Thank you again for including us, and I look forward to entertaining any questions or any follow-up beyond this website, beyond this webinar. Thank you again.
Thank you. Now our last speaker, and then we will have some questions and answers. We have Dr. Allison Whalen, who is the Chief Medical Officer for the Association of American Medical Colleges. And we've worked closely with AAMC through the years with HIPNIC Coalition, and also AAMC is part of our mentoring program for college students to get into several health professions, including nursing, medicine, dentistry, public health, and graduate school in science. Please, you have to unmute.
Okay, it's after 3 p.m. my time. After 3 p.m. I suddenly forget to stop muting. Can you hear me well?
Yes.
Thank you. So I'm thrilled to be here. And what I was asked to talk about is then the changes in medical education. And as I think about who our potential audience is, many of you have lived the experiences that physicians have had. There have been impact for your education, huge impact on resident education, and certainly on medical student education. Given the amount of time we have, I'm going to focus primarily on the medical student experience. Some of the lessons are expandable, and you'll hear some very common themes from the last two speakers as well. There's a couple slides I'm going to flash through. They are essentially AAMC resources that I wanted you to know about, but I don't need to spend any time on them because you'll have the slides later. So when I think about it, some very broad buckets of the impact of COVID-19 on medical education, particularly medical student education. Of course, the switch to online and virtual classroom learning, the major disruption of clinical rotations, including the removal of students at most schools from all direct patient contact for several months. And I wanted to spend a little bit of time, we've already talked about how it really has highlighted the importance of social determinants of health gaps in care and therefore in education, and some new gaps that we recognize in medical education or have been reemphasized. And then I wanted to talk briefly about what I think the best term is really the social determinants of education for our learners, and importantly, how we can fill those gaps and support those gaps. Next slide, please. So when we think about this, there have been some real positives from this as well. And I wanted to start out by emphasizing that I cannot tell you how impressed I have been with everyone involved in healthcare world and in healthcare education. Clinicians were redeployed, residents had to shift what they were doing. Students were flexible. When they were pulled from rotations, they jumped in and created incredible volunteer activities, and their educators were nimble, flexible, and really committed to the care of the community, the care of patients, helping students continue to learn, but also keeping everyone safe. And really just a tremendous combination of things. And so there have been some great things that have come out of this. I'm not going to read it all, but as the switch to online and virtual classroom learning, anything that you can think of, innovations occurred. Anatomy, virtual anatomy was changed, really recognizing what we've been talking about anytime, anywhere collaboration for a long time, what's actually happening now, and rethinking really how we teach, how we learn, and what our students need to do and be together. It also highlighted some challenges that have already been spoken about, and that's that there are costs, high-tech costs of simulation. We don't always have experts to do the instructional design. And it's a small percentage of our students, but some students with learning disabilities were particularly challenged and unexpectedly as we moved to more online learning, and support had to be brought in for those students. Or they struggled as they didn't understand that that was the issue. And then, of course, bandwidth and privacy issues of work from home for both the faculty and the students. And the next slide. We can go on. When we think about the disruption of clinical rotations, again, students were pulled from clinical rotations for several months. That you've already heard about the innovations in telehealth and telemedicine, virtual OSCEs, telelearning, and really importantly, recognizing that as you disrupt what you've normally done, to graduate competent, confident students and to let competent residents move on, really focusing on what is it they need to be able to show that they can do. So that's competency-based education. How do we have to change up our tests, and what do we need to be doing differently related to that? We did identify, though, with these innovations that there are education gaps in telehealth. What do students need to know? What do faculty need to know to be able to do that? New ethical concerns. And again, as we think about competency-based education, we really need to come up with new assessments. I wanted to highlight these two areas of the challenges. On the next slide, we think about the education gaps in telehealth. AAMC had already been working on this since over a year ago. At the time, about a year ago, very few schools were teaching telehealth. Most schools were beginning to think about it. We had begun to develop a set of telehealth competencies, which are on the next slide, which is really saying, what is it that every graduating student, every graduating resident, every faculty member should know about telehealth? We've accelerated it by a couple of months, and we'll have our competencies available. I just reviewed today, so ideally August, but for sure by September, and the report will be done in 2020, which will serve as a great foundation for that. The next slide, I'm going to talk about the ethical challenges that were unique to COVID, and that was the idea for students when they were pulled from rotations. It wasn't primarily for their safety, it was putting public health and health professional safety in the light of insufficient PPE ahead of individual or needs, something we've never had to do as educators before. For residents, when they are redeployed, again, they put service needs dramatically above learning needs, and sorting out what that will mean for them as they finish their training is still a work in progress. And importantly, for our practicing physicians who are redeployed, really thinking about their personal safety versus clinical need. And then competence, what do they need to know to be redeployed? Pediatricians were brought to take care of adult patients, general internists were brought into the ICU, and thinking about how we as a medical community support those individuals so they can be confident is an ongoing discussion. Next slide. And then really importantly, we've talked about this already, the social determinants of health gaps and education gaps in education. Of course, we need to understand the new virus, but it's really brought to the fore that we need to really enhance public population health, really teaching social determinants of health and the impact of that on the health of our nation, the health of our individual patients, and importantly, anti-racism and bias training and equity, diversity, inclusion, and as I already mentioned, the competency-based education. In all of these areas, we've had huge collaborative sharing, and I think one of the great challenges going forward is will our medical educators continue that degree of collaboration and sharing, because it has been striking and really has helped to move the needle. On the next slide, talking about our equity, diversity, inclusion resources, MedEd portal has a series of education modules related to anti-racism. We are developing, just like with telehealth, a series of equity, diversity, inclusion competencies across the continuum. They'll be available this fall as well. The description is on our website. And really importantly, our constituents, so the leaders from each of our medical schools have come together, and they have created a small work group to really think about anti-racism and bias that they can do within the medical schools, both in teaching, but also in the physical environment, in the visual environment, in the language that they use in their policies. So that's ongoing work as well. And the next slide. You can skip this one. That's a description of the MedEd portal. You could look at it at your leisure. And again, the diversity, equity, and inclusion competencies across the continuum will be available in October. And again, it is, what does every medical student need to know? What does every resident, regardless of specialty, and every faculty member? So stay tuned for those. It's focused on MDs, but it's really relevant for all health professionals also. The next slide. Wanted to spend a little bit more time talking about this concept of social determinants of education and how it has really highlighted for medical schools how they need to really address those gaps. You've already heard that there's greater personal and community impact of COVID on our Black and Brown students, both for them individually and for the communities in which they live. Students of any lower socioeconomic status, whether they're Black, brown, or white, also face more barriers for effective online learning. It's the cost of technology, it's the physical setting, and it's geography. And the most striking area is actually rural students have the lowest access to high bandwidth. And that can be a real concern, particularly as we send our students away from the campus, most of them went home. And then it can't be separated. The simultaneous trauma of the police violence and the energy that it has taken for the students who have been part of the ongoing protests for that has really impacted, again, our Black and Brown communities more significantly than the other students as well. Then there are also gaps with schools and programs. That the cost of switching delivery is substantial. Some schools have much greater resources, and the impact on patient populations was different. Some hospitals emptied out, some patients were unable to get to clinic, and as Winnie's already said, some patients didn't have access to telehealth, and so that again changed not just care to learning. And then importantly, as these students need extra help, the resources to bring that to bear, both financial and person resources with expertise. And this is an area that's ongoing and that our medical education community is talking about. Really need to share how we can best support these students. We've been talking about other aspects, but as new concerns come out, really sharing best practices is critical as well. Next slide. So dealing with the new normal is the title. And I just have a hard time with that because for me, it's more the lessons from the new and ever-changing non-normal. Because just when I think we've reached a new state, it changes again on us. So it's more of accepting the churn and trying to ride whatever wave you're currently on. But I did want to highlight a couple of things that I think are really important if whatever it is we're doing is going to be successful. And I have seen this over and over again among, as I said, from everyone involved in medical education and medical care. The nimbleness and innovation and passion that came out and it continues to come out is striking. The collaboration across schools, across health professions, striking and important. And when we were hit with two pandemics at the same time, and particularly when it came to the police violence and it really uncovering racism for some people for the first time, and other students saying, I've been living this my entire life, and how to have that dialogue among both groups at the same time. Humbleness and openness were the most important factors for moving that forward, both for individuals and for groups and for schools. And we need to continue that at the national level. And I think there's no status quo. I don't know what the new normal is yet because nothing has settled out yet. But in every decision that I've been involved with, whether it's making recommendations for pulling students from rotations, and every serious recommendation or decision that I've seen made by schools and by students, that when it goes back to core values and core mission and what we're really trying to do here, then we make the best decisions. And I think those are the things we need to take going forward. And when all is said and done, it's about the people. It's all about our patients. It's all about our learners, and it's all about the healthcare team. And that, to me, isn't the new normal. Those are the core things that we want to continue to emphasize as we figure out what the new normal or the new non-normal is going to be. Thank you. And I think we're on to questions.
Thank you. Oh, I'm on unmute already. Thank you very much, all of you. Excellent presentations. We have a few questions and we can stay till 8:15 just so everyone knows online. And let me just explain something. I've got a few questions. this whole session being recorded and will be available at the NHMA website next week. It's www.nhmamd.org. So let me just start. Winnie, you may be able to answer this. I'm going to target my questions, but if anyone wants to answer also, please go ahead, jump in. Winnie, there's a question about, in fact, it came from our past chairman, Dr. Sam Arce. He's a family practice physician in New York. And he said during the New York, the beginning of the pandemic, you know, a lot of people died in New York right away. And he says everybody got a death certificate that said they died from COVID. So do you think that there was, overinflation of the numbers of deaths in our communities? People that had a heart attack or people that had a stroke. I know it's a subjective question, but what do you think?
Well, what do I think is that I think two things about the data, and that is that's mostly for people who died not in the hospital, right? Because the unknowns are the people who died at home.
Right.
And so I don't know if we can say all of them got a death certificate. I know that what happened about a month, it was sometime in April, maybe even early May, that the governor, Cuomo, and probably his Department of Health decided that they decided to capture many of those deaths that occurred as COVID related. And they did so because of the other data point I wanted to make, which is that there is a difference, a significant difference in the number of deaths, both at the state level and nationally, in terms of the average number of deaths over the same point of time in a year compared to now. And so I think that was one of the factors that, I assume that's one of the factors that Governor Cuomo was making. And my state of New Jersey, we did the same about 2 weeks after New York.
Okay, well, thank you for that. So let me go to Dr. Grube. When you have advanced directives for our families, can you explain how you go about getting the advanced directives? A discussion with an expert that would tell you options. And the other, and if your toolkit has it, that would be great. But one of the questions was, does it vary by state? And when you take a loved one to an emergency room, how does the hospital know about your information on the advanced directives? Do you carry them with you to the emergency room? So just it's a simple process there.
Yes, well, it's variable everywhere, of course, and I think we need to recognize the context of where we live and our situation. If possible, and it's not always possible, our healthcare representative, our proxy, should live near us and be strong and be willing to speak to what our wishes are. That's not always possible. Yes, going to an emergency room, especially in a larger urban area where there may be several facilities, taking the advanced directive with you is very important. Probably in 2020, it's even more important to make a short video of yourself on your iPad or your phone, saying that I have brought my advanced directive. I want it to be honored, and I have determined and declared that person A is my healthcare proxy. This is so valuable for the healthcare team when you can't speak for yourself. And of course, in this time of the pandemic, with the rapid deoxygenation of the elderly from the virus, they may quickly not be able to speak for themselves. So having it with your healthcare proxy and yourself going to the facility is important. It does vary by state, and videotaping it on, if you can, or on your proxy's phone so that it's there really helps the healthcare team, I think. Thank you.
Great. Dr. Whalen, a question for you, and then I have a question for everyone. The resources that you mentioned, especially the competency-based resources and the new thinking, one of our doctor leaders on the phone or on the Zoom thinks that we should have a whole new episode just to have you explain some of the innovations that you're talking about with medical education. And that goes across nursing, education, public health. I love the term collaboration and the importance of increasing public health and social determinants of health awareness within medical education, because I went to public health school before I went to medical school and know how there's a disconnect.
Yeah.
But are these resources, the real question here was, are the resources going to be available to the public, or what you're talking about, is that just available to your own diversity and inclusion officials?
Yeah, so a couple different things. The MedEd portal resource that I mentioned. So what MedEd portal is, it's an open access journal of education modules and innovations. It's freely available to everyone. It's open access to anyone, free and downloadable. I actually put the link in the web there. Our competencies across the continuum will be available publicly. Again, the equity, diversity, inclusion ones will be available later this fall. The telehealth ones will be sort of published ahead of print, because we always do it. We're going to have a formal report, but because there's such an interest, they'll be published earlier in the fall, probably by the end of September on our website, and those will be available to everyone. And again, it was focused on physicians, but we did have a nurse on a panel for all three of those, and included both experts in the areas, either telehealth or equity, diversity, inclusion, and general educators as well, trying to find the sweet spot. And if people are interested, it wouldn't necessarily be me, but we would love to come back and have a discussion about the competencies and about how to use them.
That would be great. Thank you. Winnie, I know people asked, and I'd like you to just tell everyone your website that you have with all the valuable information that you put on.
Thank you.
Can
It's www.campaignforaction.org. So I typed it in the chat box too.
Yeah,
And it was on my last slide.
Okay. And then there's a question for everyone, if I can have each of you answer one at a time. The importance of the mission, your mission of your organization. How do you think the COVID-19 has modified your missions, or let's just say the commitment from leadership to take into account what we're going through this year with COVID-19? I mean, we've heard a lot of innovations, but what do you think, maybe one example of how you see the major change at the top from the leadership and the mission of the organization? Winnie, you want to take that?
I would be very happy to, and I'll speak for AARP. And that is not so much our mission remains the same, but we really have been focused quite a bit on nursing home care, because we know that has been a major part of the devastation and the deaths. So we have continued to focus. We had a very big campaign all summer long focused on that. We have to wind that down now because it's getting close to the election season. So, but we are looking at it internally. We are creating strategies to really look at improving the overall care in nursing homes. It didn't just happen out of a vacuum. It happened because there are circumstances that allowed it to happen, and those circumstances should radically change.
You want to answer, Dr. Whalen?
Sure. So the AMC's mission is, and I won't get it exactly right, but it's to lead and serve academic medicine in its communities to improve the health of all. And COVID has reinforced that mission is absolutely critical. We have been living it every day. And what has been striking is that everyone in the organization has pivoted So where we are spending our time and how we are supporting our schools has been very COVID focused, but still very, very mission driven. We've always had an advocacy arm, and we have been doing more and having more statements, both on our own and with other associations and organizations in response to those things that we feel that are particularly federal actions that are not responsive to our mission, which is improving the health of all. So that's been very active as well. And we've had a new CEO who started a year ago, July, and a great leader for the time in that he has really stepped up. And I mean, one of my favorite comments actually was we had put out a roadmap for COVID. We also put out a roadmap for diversity and inclusion, which is start internally first. And statements about the police violence. And there's a lot of energy internally, a lot of energy externally. And 3 weeks later, he said to the leadership team, you know, the police violence and anti-racism is no longer the front page of any paper. It is still the front page of our work as well as COVID. So I'm really proud to be working for him and at the AAMC now.
Thank you. Dr. Grube?
Well, thank you. Compassionate Choices mission has always been to try to advocate and educate individuals and empower them to have end-of-life choices and options that aligns with their wishes and values. I think COVID has made us more focused on that because of the urgency of the issue. So what I spoke to tonight has become an even more significant focus for our organization. We've always been very involved in patient-centered care, but I think we're moving more to realizing that sometimes it has to be patient-driven care, and particularly when pandemics enter the arena, and so many times the choices and options are diminished. So I think it's really focused us again, and we continue to try to do our best to help people be able to achieve their wishes and values at the end of their life.
Mm-hmm. You know, I know there was a few other questions. I'm not going to get to them. We're about to the end of this session. I just wanted to tell everyone that COVID-19 has been a remarkable learning experience, and we are going to continue, and this is a slide up here. The National Hispanic Medical Association now has 17 chapters that we've developed since 2013. We started with 6 regions, and then now we've gone into the city level. A couple of the chapters have joined together, but these are going to be Zoom meetings over the next 2 months. And starting in September, our heart disease and our healthcare workforce focus for California in a couple of weeks. And then we'll continue in Boston and Phoenix with diabetes, challenges and opportunities, again with COVID. And then we will have Chicago and Indianapolis talk about diversity in healthcare. And I have to say that the Blue Cross Insurance Company there is very interested in. We found that the diversity and inclusion is not just in medical education anymore. We're seeing it in different parts of our healthcare institutions. And then in October, we will have 5 different seminars. New York talking about the reflections of the front lines, some of our members who are nurses and doctors in the front lines. The Gulf Coast chapter is going to talk about their own research that they've been doing. The leader there is an intensive care doctor, and working with the Ochsner Health System and LSU. And then in Rio Grande Valley, El Paso, and San Antonio are coming together to just have one big hour-and-a-half session on border communities and health given COVID. Our DC chapter is going to focus on health literacy with a speaker from the CDC. And the Miami chapter is going to talk about immigrants in the detention centers in Miami. Some of the physician activists have been taken care of there. And all of them are also going to talk about the importance of our role in empowering our active members, as well as those who join our networks. And we invite everybody to join NHMA. You don't have to be a doctor to join. So we are going to be actively educating our networks about experiences from our experts that we like tonight. And I want to thank you again, Dr. Grube, Dr. Whalen, Dr. Quinn, and want to thank AARP. This has been a pleasure to have 4 sessions. We will continue this, and all of those chapter meetings will be national, open to everyone. The speakers will be a little focused on regional priorities, but we will encourage everybody to get involved with clinical trials and to help with their own medical education efforts in their medical schools and residencies. And we want to thank everybody again, and it was a pleasure to moderate these 4 sessions. And I will not be moderating the next 2 months. Got to get the chapter leaders to start, moderating. And so anyway, I'm going to leave the meeting, and again, thank you all very much. We'll have the recording on www.nhmamd.org next week. Thank you.
Thank you, Dr. Rios.
Thank you.
Thank you.
Thank you.